Our first question is, do you find in your practice it difficult to prevent hypoglycemia during pregnancy when trying to keep blood glucoses well managed?
The answer is no, is because we don't give enough carbohydrate in order to take large doses of insulin. The biggest reason for hypoglycemia is that large doses of insulin are given. If you give large doses of insulin to cover a meal plan, there's always a fear that 2 hours later a woman will be hypoglycemic. So minimizing carbohydrate in the meal plan also means minimizing the bolus or the amount of insulin you need. But we always make our women check their blood sugars really about every hour anyway, which they're happy to do. And it could be that a continuous glucose monitor could prevent hypoglycemia because you could watch the blood sugar falling before it actually bottoms out. But the truth is, I don't have trouble with hypoglycemia because my women are measuring their blood sugars so frequently that they can tell the rate of change and know they need to nibble something or eat a snack or at least have a little juice so that the problem doesn't happen. So we prevent hypoglycemia. We don't really let it happen. You sort of get used to knowing which women are very insulin sensitive, and therefore if they take an extra unit or so extra, they have to really eat extra or eat again an hour or two later.
Thank you very much. Okay, next question. It seems from the glucose sensor profiles that peaks are noticed closer to the 2-hour postprandial. Would it be beneficial to do the self-monitoring of the blood glucoses at 2 hours versus 1 hour postprandials?
It is difficult because there are subcutaneous sensors. The problem is it takes a while. It's subcutaneous sensor, so it's tissue juice, so it isn't completely accurate, and it takes a while for the glucose to end up in the subcutaneous fluid. That's why you're absolutely correct. Wow, whoever asked that question is a genius. It really does take longer for the sensor to see the high points. That's why that's why we're doing the clinical trial. Sensors may not be safe during pregnancy because they're too slow, they're too inaccurate, they don't tell the truth quick enough, but we'll find out because it's a randomized trial of multiple glucose checks versus continuous sensor. The outcome variable is macrosomia and complications associated with pregnancy. That trial is starting recruitment, so if anybody wants to refer their patients to us, they can go to the JDRF website. JDRF is funding this, and find out what center is close to you to have your patients. You get a free glucose sensor, so it's kind of fun. But the truth is the eligibility criteria are really easy. Just want to become pregnant and you want to answer the question of whether a sensor is safe and accurate during pregnancy, or should we always tell women they really have to do finger sticks.
Okay.
But I'm impressed with the question.
So am I. Okay, next question. Once metformin crosses the placenta, how does it affect the fetus?
Okay, now I'm going to tell you something of just Lois's opinion. This is only Lois's opinion. Metformin decreases insulin. It's an insulin, it helps lower the insulin level. It's the reason we give metformin to women with PCOS to decrease their insulin level. So it's possible that giving metformin is a good idea if you already know that the baby is macrosomic and insulin resistance, because you can already tell the baby has visceral adiposity. I mean, so it is possible that we'd be suggesting that you give metformin to any woman at risk of having a macrosomic or insulin-resistant baby. But the truth is you'd want to know the safety and efficacy of those trials. And right now there are international studies going on looking at the safety and efficacy of metformin to treat type 2 diabetes and to treat gestational diabetes. Most of the authors are not in the United States because it isn't a Category B drug. But the truth is, if you ask Lois, it could be that we find out metformin is awesome because it does get to the baby and would help the baby decrease its insulin resistance syndrome. But that's only a Lois opinion.
Yes, but that's a good opinion. Okay, next question. Can you address isolated impaired fasting glucose as a risk factor for adverse outcomes in comparison to postprandial elevations of glucose?
If the fasting blood glucose is greater than 140, you could say absolutely yes. There's no way if you're starting the meal greater than 140, you could have a postprandial less than 120. I mean, if you're starting the meal higher than 120, there's no way you can have a postprandial less than 120. But the truth is, if indeed you're normalizing the fasting, that's not the only blood sugar you have to fix. Fixing the fasting does not fix the whole problem. So just giving NPH before bed is not sufficient, or sending a patient to the lab just for a fasting glucose to feel as though there isn't still glucose intolerance. So the truth is, if indeed, what I would end up doing is handing a woman a finger stick glucose monitor, giving her a bottle of strips and saying to her, measure your blood sugar after really a meal with a high carbohydrate content. If your meal is above 120, come back to us, because obviously you need help with nutritional counseling, because it is true, whether or not the doctor says you have gestational diabetes or not, you need help with nutritional counseling.
Okay, next question. Can you make a recommendation in regards to initiating and titration of Detamir?
Oh, that's interesting. Because I was on the papers, but because Detamir wasn't a Category B yet, Novo Nordisk didn't want me to be a researcher. But the truth is, what you do is you calculate big I based on that formula I showed you. So it's based on gestational week and weight in kilograms, and then divide it in half, so 50% is the Detamir. Well, what you want to do now is give 1/3 in the morning and 2/3 at night. So if indeed your dose of Detamir during your basal dose were, let's just say, 21 units, you'd give 7 in the morning and 14 in the evening, because actually it's the overnight dawn phenomenon you're treating with your evening insulin. So yes, it's still 50% of big I, and you divide it so 1/3 is in the morning, and 12 hours later you give 2/3 of 50% of the total dose. Did I explain myself, Cynthia, or is that confusing?
No, I think so. I got it. Plus, it's
good.
going to be on our audio for people to go back and see, and they can always email me saying, okay, I need a little extra information.
It's still, right. It's still 50% of your total insulin requirement, and it's divided such that 1/3 is before breakfast and 2/3 are 12 hours later, which usually is before dinner.
Okay, next question. With only 33% of calories from carbohydrates, aren't you providing too much fat in the diet? And is that not also unhealthy?
Well, you know, cholesterol makes hormones, and I'm not trying to prevent cardiovascular disease, but probably cardiovascular disease, if you look at all of the trials, it's really related to glucose and VLDL, which is a glucose moiety, and a lipid moiety, which is very much related to insulin. So the truth is, I'm not forcing my women to eat fat, but I don't care if they eat fat, because fat really doesn't convert to glucose. I'm taking care of the baby, and I tell my mothers that. I say, you know, I have tunnel vision to take care of your baby. I'm going to give you a healthy baby. It doesn't mean the principles I'm teaching you at this moment are really what you're going to be taught by your dietitian or your physician when you're not pregnant. But the truth is, if you normalize glucose, usually you normalize the lipid profile. And I'm not giving a lot of calories, as you see. So if you looked at total grams of fat in the very small diets I prescribe, it's not a whole lot of fat. It just tends to be a larger percent of the meal plan fat rather than carbohydrate.
Thank you. What are your thoughts on continuing metformin after the first trimester in women with PCOS?
As I say, I think it's not necessary. First of all, those studies are very unclear. They didn't look at glucose. They just looked at spontaneous abortion rate. And the reason I critique those studies is because metformin probably helped decrease the spontaneous abortion rate because it was treating the glucose a little bit. So compared to placebo, of course, giving a little treatment was better than giving no treatment. But the truth is, if you're going to insulin, metformin doesn't treat the postprandial. So you would have to give pre-meal insulin anyway. And I don't know how to calculate the insulin dose if you're continuing the metformin, because I've never done that experiment. And metformin is not a category B drug, and therefore, as you can hear, I'd rather, if I'm teaching insulin, teach insulin. Metformin would confuse me, it would confuse the patient. And if the studies come out that metformin is good to prevent neonatal hyperinsulinemia, you bet your boots I'll learn how to use it, but at the moment I don't know how to use it. So as soon as a woman is pregnant with PCOS, I usually suggest we immediately go to insulin and do what I know how to do best, and that's how to prescribe insulin.
Okay, next question. Does acanthosis nigricans decrease when treatment is initiated?
Yes. You know, it's actually true. I should be taking pictures of these ladies, but, you know, they actually notice during their pregnancy, of course, they have a lot of estrogens, too, which help because that also, estrogens sop up testosterone, which decreases the acanthosis nigricans. But the truth is they do notice the lines are going away. They start to notice they're not as hairy. I mean, it's really lovely to see. And so I say to them, you know, it's a reason to keep doing this for the rest of your life because it's a cosmetic reason now. The acanthosis nigricans can be embarrassing to some women. They never wear sleeveless dresses. They end up wearing scarves so you can't see the back of their neck. You know, they go to dermatologists. I mean, it really is a part of life they would prefer not to have. But the answer is yes. You normalize glucose, you can normalize the insulin level, and you decrease the acanthosis nigricans.
Oh, that's good to know. Do you see poor fetal growth due to the low carbohydrate diets?
No. I'm not starving anybody. I'm not giving them malnutrition. I do ask them to take a multivitamin because, of course, if I don't want them to eat citrus fruit, and that falls off the trees here in California, so it's free. But the truth is I'm a little worried that some of the diets I'm prescribing may not give them enough nutrients. So as long as they're taking a prenatal vitamin, I feel very, very good that they're getting enough carbohydrate in all the vegetables I'm allowing them to eat. And the truth is I do allow them a little milk, and milk has got lactose in it, which has, you know, carbohydrate. So I'm really not causing low growth of fetuses. If indeed, if their blood pressure is going up because they have undiagnosed type 2 diabetes, yes, I'm concerned that the kidney specialist is going to put them on a kidney diet, which really has no protein in it. So you can understand it gets more complicated if they have type 2 diabetes if you get other kind of specialists involved. But the truth is that I've never seen low growth based on low carbohydrate, but I have seen glucose junkies, women who are so afraid to have their blood sugar go above 100, they keep their blood sugar at 60 all the time, and they've had smaller babies. It is true there's a U-shaped curve whereby if your blood sugar is too low, the baby really is smaller.